Hi everyone, my name is Sophia Flesh and welcome to my presentation on a community needs assessment that I conducted for a class at the University of New England. To start off with an overview of the topics that will be covered, I'll give a brief introduction of myself as well as the process and purpose of a community needs assessment, discuss who my community of interest is, go over their demographics and key findings, and ultimately their unmet critical nutritional needs. And then I will state the proposed solutions and recommendations. So as I mentioned, my name is Sophia Flesh. I'm a registered dietitian nutritionist. I currently have a Bachelor of Science in Dietetics from Michigan State University. I completed my dietetic internship at North Shore University Health System, and I am currently a Master's of Science candidate in Applied Nutrition at the University of New England with an expected graduation date of December 2020. My professional background includes 6+ years of food service and nutrition experience, and I currently work as the Senior Nutrition Manager on the Nutrition and Operational Support Services team within Aramark Correctional Services. The doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition. This is one of my favorite nutrition-related quotes by Thomas Edison, and I think it's the perfect segue into why we as nutrition professionals conduct community needs assessments. So what is a community needs assessment? It is defined as an efficient and widely accepted methodology to showcase the health of a given community. In order to do so, we must examine the demographic, geographical, cultural, and epidemiologic data, as well as their healthcare capabilities and associated and available resources. The data obtained from a community needs assessment is an integral aspect of the planning, implementation, and evaluation of current and future public health programs, which ultimately improve public health. So for the purpose of this community needs assessment, we are going to be focusing specifically on a community's unmet nutritional need. Therefore, the first step is defining a community of interest or target community. As myself was born at 28 weeks prematurely, I've always been interested in the pre- and postnatal and nutritional care of pregnant mothers. So with the cost also of healthcare rising in the United States, I know that low-income mothers and their future children are at risk for deficiencies and obesity later in life. Therefore, for the purpose of this community needs assessment, first-time mothers living at or below the poverty level in major metropolitan cities in the United States is going to be what I evaluate. And since I currently live in Michigan and right outside of Detroit, Detroit will be my metropolitan city for my community. So using information from multiple community and professional sources, such as the U.S. Census Bureau, U.S. Department of Agriculture, Michigan Department of Agriculture and Department of Health and Human Services, pediatrics and pregnancy surveillance systems, the Institute of Medicine recommendations, as well as a key informant interview with an anesthesiology resident and neonatal dietitian all contribute to obtaining data on my community of interest and their associated demographics. In terms of race and ethnicity, In terms of race and ethnicity, African Americans represent the highest demographic in Detroit, with the second being Caucasian and the third being Hispanic. African Americans and females, specifically between the ages of 25 and 34, represent the highest demographic living in poverty. I think it's important to note that the age range for optimal childbearing years is 20 to 35 years old, which represents the majority of this group. Socioeconomic status takes into account education, income, and occupation. Therefore, the median income of individuals living in Detroit is just over $31,000 a year. There's an unemployment rate of 31.9%. And only 2% of Detroit's population has a college degree, and 29% of that 2% is of African American descent, which again represents the highest demographic living in poverty. Health literacy is defined as the degree in which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. For that reason, it's a very important determinant of health. Health literacy is definitely more prevalent in low-income populations, and a mother's education and current health status is a strong predictor of a future child's nutritional status and risk for obesity later in life. Food insecurity is defined as the disruption of food intake or eating patterns due to lack of income, employment status, access, transportation, etc. In 2016, 31.6% of low-income households were food insecure. There are some racial and ethnic disparities that contribute to food insecurity as well, as African Americans are 2 times more likely to be food insecure compared to the national average. Living in food deserts or an urban area that lacks accessibility to quality and affordable food is also a characteristic of food insecure individuals. Food deserts typically have an abundance of low-cost and convenient fast food options, with small grocery stores that are poorly stocked and lack fresh fruits and vegetable options. Food insecurity is associated with higher rates of chronic disease and ultimately negative health outcomes. And if children live in a food insecure household, they have a higher risk of developmental and mental health outcomes. When individuals are food insecure, they are most likely eligible to participate in food assistance programs such as SNAP and WIC. So SNAP, or the Supplemental Nutrition Assistance Program, or food stamps, has over 1 million participants just in Michigan alone, which the majority of these participants reside in Wayne County. 68 of SNAP participants report consuming less than the recommended daily fruit intake of about 2 cups, and 88% of SNAP participants report consuming less than the recommended daily vegetable intake at 2.5 cups. Moving on to WIC, which is Women, Infants, and Children, has just under or just above 54,000 participants in Michigan alone. Again, Wayne County contributing the largest number of people participating in this program. 61.9% of these participants are overweight pre-pregnancy, and over 50% gain more weight than the ideal amount recommended by the Institute of Medicine. Looking at other maternal health indicators, anemia in the 3rd trimester is also prevalent at above 50%, whereas postpartum it does decrease, but not by a lot. It's at about 35%. Gestational diabetes in WIC participants in Wayne County specifically is around 6%. Hypertension is around 11%, and those who are planning pregnancies and taking multivitamins prior to pregnancy is below 25%, but WIC participants do see an increase in the multivitamin and prenatal vitamins after participating in WIC. It's over 80%. Non-communicable diseases, or NCDs, such as obesity, type 2 diabetes, cancer, and cardiovascular disease, is very prevalent among my community of interest. Michigan is consistently ranked in the top 10 to 15 most obese states in the United States. Over 45% of women living in the United States are overweight or obese, placing themselves at risk for NCDs, and this percentage is disproportionately high among low-income women. 85% of low-income mothers retain significant weight following delivery, and the percentage of women who are overweight or obese increased by 6% when compared to pre-pregnancy 12 months postpartum. Postpartum is a critical time when weight retention and weight gain can lead to long-term increases in fat adiposity, therefore worsening health problems related to obesity and being overweight. So the statement of the critical unmet nutritional need. So first-time mothers living at or below the poverty level in Detroit, Michigan, present with several NCDs and as a result have unmet micronutrient deficiencies. Specifically, they are deficient in micronutrients that are normally obtained from a prenatal or multivitamin, or if they consumed a diet adequate in the recommended amounts of fruits and vegetables, such as iron. These micronutrient deficiencies can be exacerbated when presented in conjunction with NCDs, they can worsen or they can give rise to other NCDs and or lead to other adverse psychosocial health effects such as stress, anxiety, and depression. My proposed solutions and recommendations are, since there are so many local and federal community health programs related to mothers in Detroit, such as WIC or Detroit Mama Hub, my proposed solutions and recommendations will be enhancements to current health programs. The implementation of education and counseling sessions that use constructs from the trans-theoretical model to help and analyze the effectiveness of the program by monitoring and increasing their readiness to change their current habits, both during pregnancy and following delivery of their baby. The focus should be on self-efficacy or increasing their own internal self-confidence and improving their personal readiness to change, as those two factors are extremely correlated. Social support from a nutrition or medical professional and peers is crucial in this process. One way that we can increase social support is through social media or social media campaigns. They have the ability to influence voluntary health behaviors of consuming a balanced diet and achieving adequate physical activity, all things that will decrease the risk of NCDs, and a balanced diet will help address some micronutrient deficiencies. The topics of focus for education and counseling sessions would be how to consume an adequate diet during and after pregnancy on a budget, of course, and we can do this by providing sample recipes. We can also focus on how to consume more fruits and vegetables specifically and on a budget, so by providing sample grocery lists, and then just providing general education and resources on breastfeeding and formula feeding. So we can talk about the benefits of breastfeeding, which formulas to purchase, etc. All the educational resources and in-person or on-the-phone counseling sessions should be written in plain language and include pictures for ease of understanding to account for health literacy levels. Here are my references. Thank you.